also want to just briefly refer to the relapse refractory setting and make sure everybody understands that not only are BTK inhibitors appropriate for the front line, but they're also appropriate for patients in the relapse setting. We do know that patients who actually get chemoimmunotherapy in the front line will do very well with ibrutinib or acalabrutinib in the relapse setting. And in fact, a recent trial known as the ASCEND trial led to the approval of acalabrutinib in the relapse setting. It was a trial that compared acalabrutinib versus another novel agent, idelalisib and rituximab, a PI3 kinase inhibitor. There were also some patients compared to who got bendamustine and rituximab. And that ASCEND trial in relapse refractory CLL patients showed a significant progression-free survival advantage for those patients who got single agent acalabrutinib over the idelalisib or bendamustine and rituximab arms. That was the first trial that compared two novel different drugs in a randomized setting. The most important part about the ASCEND trial in the relapsed setting, however, again for me, is the tolerability of acalabrutinib. It appears to be an extremely well-tolerated therapy. As we move through 2020 and beyond, clearly we have made major advances, but we're just getting started. I think one of the things that we're going to learn very quickly in the next upcoming many months is the idea of stopping treatment and who that's appropriate for and who it's not appropriate for. If you're in the community and you're treating CLL patients, however, right now, if you're on a single agent BTK inhibitor, patients should be treated indefinitely, either till progression or some intolerance. Alternatively, a very appealing regimen is that venetoclax obinutuzumab regimen that gives time-limited therapy. It's a year in the front line of the combination, or 2 years of venetoclax and rituximab in the relapse setting. But important to remember that with venetoclax, there's a high risk of tumor lysis, so you have to be very diligent, follow the ramp-up schedule, and to pay attention to the patient and those laboratory parameters. The evolution is now, though, in combinations of treatment. The combinations will drive us to time-limited therapy, undetectable minimal residual disease, and sequencing of agents. Hopefully what this is going to do is really work towards something we never talked about in CLL before, and that's curing these patients with standard treatments.